Welcome, Dr. Yi, to our 2023 seminar series. Dr. Yi has been an epidemiologist and population health researcher for both universities and governments for 20 years. His research interests include population health metrics, cancer epidemiology, environmental epidemiology, and public health program evaluation. Dr. Yi is currently Provincial Epidemiologist and Director of Epidemiology for BC's Office of the Provincial Health Officer. His team uses administrative health databases, health survey data, and open data sources to assess population health status and inequalities in BC. The team provides analytical supports to the illicit drug toxicity crisis and the COVID-19 pandemic responses. Previously, he was a nil-salaried assistant professor of epidemiology with the University of Manitoba, where he led several epidemiological research grants as principal investigator and an adjunct professor with the University of Ottawa School of Epidemiology and Public Health. And now I will hand it off to you, Dr. Yi.
Great. Thank you very much for introduction, and thanks for the opportunity to present our work around population health metrics in BC. I'm talking about the current state challenges and the opportunities in the future. I'm calling in from the traditional territory of Lokankin people and the Hausanic people. I want to start with this slide about the inherent rights of Indigenous peoples. Since 2021, we at the Office of Provincial Health Officer have been making efforts to unlearn and undo the ways in which white supremacy and racism show up in our policies, practices, and approaches. One of changes we have made is to acknowledge the inherent rights of Indigenous peoples at the beginning of all our documents, presentations, and reports. That's why today I will begin by acknowledging with gratitude that First Nations territories stretch to every inch of this province. Inherent rights rooted in connection to lands and waters have never been ceded or surrendered. Inherent rights are upheld in international, national, and provincial law. Long-standing indigenous laws and systems are tied to the land and the waters of these territories. And generations of indigenous rights holders who are First Nations, Métis, and Inuit from elsewhere in Canada also call these lands and the waters home. So in my today's discussion, I will talk about mainly three things. First, I will start by describing what are the principles and the framework for population health surveillance system. And then I will describe briefly some of our surveillance work around morbidity, mortality, risk factors, and health inequalities. I will also briefly mention our collaborations with our Indigenous partners to uphold Indigenous data governance. So while I'm talking about these activities and works, I will mention or discuss some of the challenges we are facing and what are the opportunities to enhance the work we are doing today. I want to start with some basic terminology. Indicator, metrics, sometimes measures and measurements are terms often used interchangeably, but they are slightly different. An indicator is a measurement that affects a given situation. Typically, it's for given one health dimension. On the other hand, metrics oftentimes reflect more complex of multi-dimensional phenomena of health issues. For example, here, for physical activity, we would ask questions about the type of physical activities, durations, and intensity. And based on that type of information combined, we can actually calculate the value of physical activity. And for health, other indicators, for example, we could add health quality of life and life expectancy together, then we will generate a health adjusted life expectancy, which we have multiple dimensions. And for health inequalities, we have something like a Gini coefficient. So there's a slightly different concept. individual and population health determined by many factors connecting to each other, including social environment, such as socioeconomic status, living condition, physical environment, such as pollution, and the person's genetic profiles. It's also determined by individuals' response, such as individuals' health behaviors, including smoking, drinking, diet, and physical activity level, biological profiles. And of course, our healthcare system also plays a very important role in determining the people and individuals' health. So what that means is for us to monitor population health, we will not only monitor the status or health of individuals and populations, but we also need to consider and monitor the determinants of health. And based on that concept, the principles, there are a number of population health monitoring surveillance indicator framework have been come up. This is one from StatScan and CAR-HI. As you can see here, the framework includes majorly three major big components. The first is around health status, including people and the individual or populations, morbidity, mortality, and well-being. And the second is the three-dimension of determinants of health, including here is called non-medical determinants of health, which is health behaviors, living and working conditions, and the environmental factors as we just described. And as I mentioned, healthcare system, the accessibility, the effectiveness, the cost, and the safety of the healthcare system also has very big impact on our health status. And of course, the community we are living that also has an important role. And often it's important to apply the equity lens to both the health status and the health determinants of health factor assessment. One of the challenge, as we say here, there are so many dimensions for monitoring population health. One of the challenges is we could end up with hundreds indicators that people think are important and are interested to monitor. So many years ago, when I worked in Winnipeg, Manitoba, so when I started a job, I was told that there were about 250 indicators the group is interested to monitor and for population health. In my opinion, that's just too much. And what we end up to do is we set up a set of criteria to access each of these indicators based on the 5 criteria listed here. We look at each indicator about whether they are important, whether they are relevant, whether they are valid, and whether it means that it's measuring what we are meant to measure, and whether it's possible or feasible, i.e., if we have a data, and if we have a methodology that allows us to estimate and measure the indicators. And it has to be meaningful. It's meaningful and it's sensitive to reflect the change at the population level. And finally, has to tie to population health, public health actions. So these are typically the criteria we applied to select, narrow down the list of indicators or metrics we want to work on. And after that, in Winnipeg, we were able to reduce the number of indicators from 250 to about 90 indicators. That's a huge reduction, but it's still, in my opinion, it's still quite a lot, and there's a lot of work to do. Based on a similar approach, a similar principle, the Office of Provincial Health Officer has worked with Child Health BC to select 51 indicators for monitoring child health and well-being in BC. This is just incomplete list of 51 indicators. For a full complete list, you can go to this PHO website. And that framework or the list covers indicators for 5 dimensions: physical health and well-being, mental health. This is quite a challenging piece for us because we don't really have very good child mental health indicators, something my team and others are working together trying to find a solution. The third dimension is social relationship with parents, with the peers at the school and in the community, and economic and material well-being, and finally cognitive development. So that was the principles and concepts we normally use in terms of designing and selecting a set of indicators for monitoring population health. The next thing is how are we going to operate that? Typically, a population health surveillance framework includes 4 steps or 4 components: data, analysis, information dissemination, and decision making. So I'm going to focus on the first 2 parts because that's the most important work we are doing right now to generate the useful information for decision making. We at the Office of PHO, we don't collect data ourselves. We mainly rely on the data existing, routinely collected, or open source data for deriving the metrics for population health. For example, we use census and MSP registration database for our population source or denominator for indicators. We use health service data set, including emergency room visit, hospitalization data, drug prescription data, and the physician visits data to derive the incidence prevalence or morbidity metrics indicators. We use vital stats, particularly stillbirths and the death registry database for mortality indicators. We use a lot of survey data, such as Canadian Community Survey for health behavior, smoking, drinking, and physical activity indicators. And we also use some open source data, such as environmental monitoring data set, including air quality, climate change factors, and use that to build the indicators for people's exposure to risk factor. So that's where we consider phase 1 analysis. That's basically to look at the counts. One of the challenges with this morbidity mortality analysis is it only considers 1 dimension. For example, for morbidity, it only counts the number of people deceased, but it doesn't really take into account the severity of the disease and the level of the disease impact people's quality of life. So if we put all these dimension, the counts, the severity, and then the impact on the quality of life together, then we have one measure or matrix called years lived with disability. And then that's comparable across different diseases. And for the mortality, the same thing. Instead of counting number of deaths, we also take into age at the death, because the young age has a much higher impact to society. So by combining the 2 dimensions together, that becomes years of life lost, or YLL. And the total of YLD, YLL becomes disability adjusted life years, which is, again, a composite metrics for actually based on both the morbidity and the mortality. So that's where the phase 2, we are still learning, we are still, but hopefully we can move to, we are still graduate adopt the methodology for that. One last thing, critical information is, especially for population public health, is in order for us to design the population prevention promotion program, is what are the most important risk factors we need to tackle with. In order to answer that question, what we need is to know among these diseased people or deaths, how much or how many of these are due to smoking, alcohol drinking, air pollution, extreme heat, or extreme hot, or extreme cold. So that's what we call the phase 3 risk assessment. So I will have a little bit more information later. So we also apply FD lens to all these analysis. So where we are right now, as I mentioned, we are pretty much trying to focus on phase 1, get to the methodology right to count the morbidity, mortality. Meanwhile, we are also trying to develop the methodology for phase 2. Now, I'm going to kind of give a little bit of example about the phase 1, how the work we are doing to count the cases for different conditions. One, for example, is BC congenital anomaly surveillance system, which is a relatively new system the team is operating. So it's a surveillance system program of 33 plus major congenital anomaly that is based on multiple data sources, including the hospitalization, hospital discharge database, the vital stat still first registry, the MSP database, and the perinatal service database. And we link these data sets together to find a unique baby and their mother and link them together. And we also use some that you can see here, cytogenetics data and medical imaging data for some of the condition in order to enhance our algorithm. So one thing we did was to look at how good our algorithm based on a linked database. So as you can see here, we have quite a good algorithm performance for some of anomalies based on the sensitivity, specificity, and positive predictive value. But it's not as good as that for others, for example, congenital heart defect or urinary tract defect. So this is something we are working on by linking to other data sets such as the medical imaging data for infants and for fetus. So that's something that team is working on trying to enhance. So this tells you what are the top 5 congenital anomaly groups in BC. The most common is the chromosomal abnormalities, including the trisomy 13, 18, and 21, and there are other major anomalies. So the pattern is pretty much similar to other jurisdictions in Canada, such as Alberta and in Ontario, but there are differences by jurisdictions. The couple of limitations for this surveillance system, as I mentioned, we certainly need to improve some of algorithms, but the biggest the challenge or limitation I see is the currently the system only capture the case up to 12 months of age. We would ideally to move to that younger, old age, like 7, 14, and ideally we would have the lifetime prevalence, including everybody. So that's something that the counting probably it will be challenging, but it will probably need more kind of modern type of work, which I would briefly talk about a little bit later. Another system, surveillance system we have been working on is called BC Chronic Disease Registry. Oftentimes we call it CDR. So that's again based on linked administrative databases, algorithms. The system started with only one disease, diabetes, and gradually over the past 20 years, we get expanded, and now it includes 25 conditions. Most algorithms have been validated in other provinces such as Ontario, Manitoba, because they have primary data set as a reference standard or golden standard where we can validate the algorithm. While in BC, we don't really have that data source to validate the algorithm, but we are confident that the algorithm generated from this province would work for us because we have very similar healthcare system, very similar administrative data systems, although there is some difference in terms of the details in the algorithm. Right now, the surveillance system has data on incidence and prevalence since 2001 and 2002, and we are refreshing this surveillance system data every year. We are very close to finish the most recent refresh, which will have data up to March of 2022. This is just that these were 25 conditions included in the BC CDR. They are divided into different disease groups, such as respiratory disease, cardiovascular disease, and neurological disease. So as you can see, this is just a small fraction of overall chronic disease profile, but they are the most common chronic disease in Canada or in the world. The CDR algorithm developed based on multi-dimension of medical history. That includes, first is the type of medical services, such as hospitalization, physician visits, or drug prescription, and the number of healthcare visits. For example, for COPD, at least one hospitalization, or at least two physician visits. And for some conditions, we would also have one dimension is look back period. So for example, for COPD, we look at back 1 year about the history of medical visits. For certain conditions, we would have another dimension, which is the interval between healthcare visits. For example, for Alzheimer's and dementias, we would require at least 30 days apart between the two physician visits. So you see the algorithm can be very straightforward and it can be very complicated based on medical history. And for diabetes, as you can see here, there's quite a list of medications we are taking into account as part of the algorithms. There are two data products from CDR. The first is individual level patient registry database that is researchers can access through the PubData BC. It has been very widely used by researchers in BC and other provinces sometime. And the second data product is every year we produce a big table for sex and age specific and also standardized instance prevalence by different health level boundaries and by year. And these data are also presented at the BC CDC's chronic disease dashboard. So if you are interested, you can actually go to the website and you can have a look at the data, and you can even download some of the data by different years and geographical boundary of your interest. So the team has been working very hard to enhance the BC CDR over the past 2 decades. But we know there are still a lot of limitations of the work we can do to enhance that. I think the biggest challenge to us for CDR is because it's based on a medical service history. So we only capture the patients or cases treated in BC. Sometimes we call it a treatment prevalence. Another issue is because of that, we also are unable to measure severity of the disease. And therefore, early mild cases may not be included. And there are a number of other limitations, challenge. One of them is, for example, for diabetes. Currently, we are not able to separate the type 1, type 2 diabetes, which is very crucial information for public health and for clinical services and the researchers. So that's something the team is trying to figure out a way to do. And we have looked at the lab data, which is not working. And now we are looking at other solutions to see if we can separate type 1, type 2 diabetes. That's the two example observations about morbidity, and we have also done a lot of work around the mortality. This is a list of commonly used indicator about mortality, about mortality rate, life expectancy, or years of life lost, health adjusted life expectancies. There are many challenges for generating these statistics. So the four particular things I want to mention are, the first one is it's very hard to get stable, accurate estimation of the mortality and the life expectancy for small communities in BC, especially for the rural communities. But this is the information we know that regional health authority and the municipalities really want. So that's something we need to work on. And the second thing is, although Canada probably has the best death registry data in the world, but still we found a good proportion of cases are misclassified for the underlying cause of death, which is important for cause specific analysis and for other analysis. So I have some evidence, some data later. The other thing is, if we want to calculate a healthy life expectancy or health adjusted life expectancy, we require the data on the quality of life, but we don't have very good ongoing data for that. We have some data, but not ongoing data for that. And the last one is outdated reference for years of life loss calculation. So we are still using 75. This one is very easy to fix, but still a lot of organizations are still using this very outdated reference number for the calculations. I want to show these findings my team recently completed. So basically, this tells you a couple of things. The first, the life expectancy in BC has been increasing over the last past decades, but it started to decline in 2016. That's the year the Office of the Provincial Health Office declared opioid overdose crisis. And because of a crisis, the life expectancy in BC started declining in 2016. And after the emergency response, you can see the life expectancy go back again and almost back to the normal level in 2019. And as we all know, and we're still in 2020, the COVID-19 pandemic hit. That not only caused death from COVID-19, but it also substantially accelerated opioid overdose or drug overdose crisis. And because of that, you see that life expectancy decline again, especially among males. And the opioid overdose crisis and the COVID-19 are top two drivers of life expectancy decline in BC. One of the challenge I mentioned is to get life expectancy for small communities. A solution is to do some spatial time or spatial temporal modeling, is to estimate the mortality rate by sex and by age through remodeling, and then use the information to calculate life expectancy. So this is the example from UBC. They recently published that they just did the estimation for the life expectancy for census tracts in BC. A census tract typically has a population of 2,500 to 8,000 people. But one thing is, as I mentioned, many communities, such as the community health service area, that's what we normally use on the local health area, LHA. Many LHA and CHSs has a population under 3,000. So the challenge is how we can get a methodology so we can estimate the life expectancy for this relatively small community. That's something my team is doing to to enhance this model by adding more data, more modeling strategy. Hopefully, we are able to estimate the mortality than the life expectancy for the small communities with population between 1,000 and 3,000. As I mentioned, the accurate information on underlying cause of death is very crucial, but for many cases, immediate cause of death or intermediate cause of death, sometimes even contributing cause of death are misclassified as underlying cause of death. What the consequence of that is we got inaccurate information about cause-specific mortality. We also unable to accurately estimate what's the contribution, for example, the contribution of different causes to life expectancy changes. I just want to show you some data from other group. So this is from a study that look at how many cases in Canada, in other countries, the death cases have been misclassified. They use a terminology called garbage code, which is, we can say it's unusable or ill or misclassified code. So what they have found is in these developed countries, even we are confident we have very good quality of the death registry. Still, in Canada, 20% of cause of death, underlying cause of death, could be potentially misclassified. And of that misclassified underlying cause of death, you see the top 5 in BC are stroke, pneumonia, other ill-defined unspecified cause of death, congestive heart failure, and accidental poisoning by exposure to narcotics, which is slightly different from the data, the pattern from Canada at the national level, but there's some similarity. So this is something that we need to deal with. And the impact of the misclassification is to actually get the different, as I mentioned, different information about the mortality, but also different the pattern of mortality, which also is important for public health to set up the priorities for population health. As you can see here, there are some methodology to redistribute the misclassified cause of death. As you can see here, after redistribution, the pattern shift. The number 1 cause of death remains the same, but the number 2 changed. And you can see other also changed. For example, self-harm, certain cancers, mortality. So what that tells you that, that pattern changes, that means that has some implication in terms of priority setting. How do we do better? What I described mostly is based on counting methodology. We find a way to count the number of diseased people, number of deaths. One way of enhancing that, probably get good data, better data, is through more advanced modeling, such as disease progression modeling, spatial temporal modeling. I just provide an example from UBC, which we are also working on artificial intelligence and machine learning. And the second is to generate some composite metrics, such as daily and health adjusted life expectancy, so they are comparable across different diseases. So we know what are priorities for the whole healthcare system and for the whole society. This model describes the relationship between different health state of a population or individuals. Majority of us start with healthy, but gradually some will have disease. So there are mathematical relationship between all these health states that we can leverage to generate some of indicators or metrics. For example, we can estimate the mortality, from instance, and the prevalence. And vice versa, we can actually estimate incidence prevalence for mortality based on mathematical relationship among these states. So that's exactly the approach that the global burden of disease in Seattle they have been using to generate the global burden of disease measures every year for almost all the countries in the world. I'm not going into details around the machine learning AI but just to mention that it has been increasing use in population health surveillance. Two interesting example is one use machine learning for mental health, and the other use machine learning for type 2 diabetes. They have tried different machine learning methodology. One for method they have tried is random forest classification, basically building a random forest classifier to determine a person's disease status. A little bit more about the DALI, as I mentioned, is a summary measure of mortality and also morbidity function health loss. It has two components, YLD, YLL. The YLD is the combination of the prevalence, disability, here is a DW, stands for disability weight, and the severity. And the YLL is the combination of the number of deaths and the gap between the death age and the optimal death age, individual's death age and optimal death age based on reference lab table. And with that, we have DALI. We have been trying to adapt the methodology in BC, which we know is very challenging. The methodology have been evolving is also very, very complex. So this just some very preliminary results from our work on dementia. As you can see, the DALI has been increasing in BC by about 2% a year. Both YLD, YLL are increased at about the same speed. And you can also say that sex difference, we see much higher DALI among females. So there's a gap between life expectancy, which is purely based on number of deaths, and health adjusted life expectancy, which is based on number of deaths and also quality of life. So generally about a 10-year difference between life expectancy and the health adjusted life expectancy. That's the 10 years we lost because of different type of disease that impacts our quality of life. So you see slightly increase between the gaps, but not that obvious. So we will really need good data to measure that, but right now it's kind of a challenge. I want to talk about another thing is about the risk assessment, i.e. how we can quantify the mortality morbidity due to different risk factors. So that really two key steps is, one is dose response curve. As I provide some example, it could be different shape, it could be linear, it could be U shape, it could be a Y shape. That actually describes the mathematical relations between, let's say, smoking and lung cancer. And once we have that, and then we will get the data about exposure, for example, how many cigarettes people smoke each day. And with that to input, we will able to quantify how many, for example, the number of lung cancer attributable to smoking in BC. We don't have example for smoking lung cancer in BC, but this is something we at the office PHO have been working on. It's very at a very early stage. So this is what we are trying to do is to quantify the deaths due to hot and cold temperature. So as I said, the first step is to find the relationship between the cold temperature and hot temperature using the minimum mortality temperature as the reference. You can see that two quite different curves, which means two different relationships. In BC, or depends on which year we are looking at, about 8 to 12% of the deaths are due to cold or hot temperature, or sometimes we call it non-optimal temperature. But the majority are due to the moderate cold, because in BC we have quite a long relatively cold season. And for extreme hot, it varies by year. But what I want to show you is that for 2021, typically the contribution from extreme hot is under 1%. But in 2021, because of heat dome, you all remember, about 2% of deaths are due to the heat dome in 2021. I'll quickly mention as equity lens. There are many socioeconomic measures, but we don't have individual level socioeconomic measures. We are primarily using 2 area-based socioeconomic measures, i.e. low-income measures and the deprivation index. So this is one study we did a couple of years ago, where we look at the opioid-related deaths by deprivation index. What you see here, for the most deprived group, they have a highest opioid-related death rate. So it's quite a linear relationship here. So finally, I would like to say we, as an office, PHO has developed a very strong partnership with Indigenous partners, including First Nation Health Authorities, Métis Nation BC. And with these 2 organizations, Indigenous organizations, we have a 10-year surveillance program for both organizations. And we have jointly published the baseline report of this 10-year program. The first one is called First Nation Population Health and Wellness Agenda. That's a baseline report of 10-year surveillance program. And the second is Métis Public Health Surveillance Program. We collaborate with Métis Nation BC. We also have a third report called a Separate and Strong Report. That's the report among First Nations, women, and girls. So we have been very working closely with them. So this is the data. So we support them in whichever way they think it's most helpful. But we're happy to work with the Indigenous partners around that. So I will stop here and happy to answer any questions.